Good afternoon. We are very tired. First of all, let's stand up. At least you do some, gymnastics, so that at least for the last session, we discuss it being at least with some fresh mind, and then you end up with our conference. Yes. So we'll start by here, left side. Try just to go far as you can, okay? Then up. So for those who we can, we are going now to bend, in front, okay? Downward. We'll touch, our toes. So we are here. There is no space for those. I said for those who can. Then Josephine will go down. And Mama Philippa, down. Those who can't, they will be having problems with their muscles and joint, so they should join some sport activities at least 3 times a week. Okay, let's sit. I am called Managa Theonest. I'm the director for cancer program at RBC. So I am not presenting the panelists, because Dr. Diane, who is our MC, has presented them. So this panel is about the universal health coverage. We have got different topics discussing about what can we do, what can we do to build good health systems that help our patients. And among the things that we have to do is make sure that we decentralize our services, being treatment, but also there is something that Diane has evoked about financial toxicity. And as you know, cancer is among the diseases that is emerging among the NCDs. When you ask different people, they will tell you that they are consulting the health centers, the HS, just for cardiovascular disease, hepatitis. But till now, it is like imigani, as what we call imigani in Rwanda, something which is not understandable, that getting cancer is not easy in terms of feeling it, but also treatment is a problem. But also, we don't find maybe doctors. Some don't even know that is treatable. We still have that mindset in our population. Now, Dr. Stella, who is in front of us, with Dr. Regis and Dr. Professor Bagenda, who is live from Kenya, not here. We are going just to demystify what can we do to make sure that our population get out of fear, that they can access what they can here in Rwanda from elsewhere. That's it. So I'm going to start by presenting Dr. Stella, who is a lecturer at University of Rwanda. She's a health economist. She's the head of policy in economics at UR in the School of Public Health. She has a very long experience in healthcare in Rwanda. Among them, she's working on one important, activity that is, producing health package that is affordable in Rwanda in different domains, starting from cancer that we are going to talk about now. Please give another round of applause to Dr. Stella. I will talk about others later. Please, this is the show for you. Thank you so much.
Thank you very much.
Yeah.
Thank you very much for having me. It's a pleasure to be here, to be part of this great conversation and important conference on cancer. As he just mentioned, I'm a health economist from the University of Rwanda, and my interest is in using economic evaluation evidence to inform policy and guide prioritization, and more importantly, developing health benefit package to improve equity and access to affordable healthcare services. Can I have the presentation, please? My My focus will be on the journey that Rwanda has embarked on in terms of designing a health service package for cancer services with focus on community-based health insurance. Just a quick recap. Can I use this one? One of the panelists yesterday said that there are 8 action points for Africa. I'm happy it's in front of me. I'm struggling to use the... Maybe I can... The first, my focus will be on the third one, improving equity in I'm struggling to use the... Improving equity, helping countries to design a health benefit package for oncology services. And the timeline, this have to happen in 5 years. So currently, I'm going to share how far we are in Rwanda in terms of designing a cancer benefit package. Before, I want to help you understand what is the health benefit package, how is it different from a service package. Currently in Rwanda, and I'm happy I'm with the manager of the biggest schemes in Rwanda, the CBHI and RAMA schemes. We have what we call a service package, which describes services that the government is providing or is aspiration of the government toward the citizens. But when it comes to the health benefit package, it's a different story. Here we are talking about a list that the payer, the purchaser, is able and is willing to pay to maximize the health outcome within the available resource envelope. It means that we need to design an affordable package, and also that should be accessed by the citizen, not just saying we are having a list of services, and when you go to the facility, you are not able to access and use those services. Initially, there was no distinction between these two service packages, but lucky enough, in 2020, there was a ministerial instruction that was put in place highlighting the methodology of adding or removing the services on the benefit package, because it was very hard for the scheme and for the payer to decide which service to include on the package. As we all know, we have new technologies, we have new health cadres, we have new centers, but some of the services are not yet paid. So it was a puzzle for the scheme to decide which one to include, which one not to include now. So now the ministerial instruction was there to help to make informed decision on how to include new services, and if need be, to remove unnecessary services to the package. The ministerial instruction provide a framework and also set up a committee. There's a committee composed of 17 members, which is responsible for defining a community-based health insurance benefit package. But this committee cannot work alone. The committee needs people to support. The committee needs people with expertise to help generate evidence. That's how the School of Public Health comes in, to help the committee members to select new interventions, especially cancer intervention, to be added on the service package of CBHI scheme. The ministerial instructions again define criteria, because if malaria is competing with cancer, cancer is competing with disability, disability is competing with diabetes, there should be criteria to say we are adding these new services and we are leaving these services. There are about 10 criteria. One is a burden of disease, financial risk protection, budget impacts, and so many others. In a few words, government is willing to pay a service that provides most health outcomes, and also is also ready to pay for services that target the most important disease conditions. And also, we should select services that are feasible to implement, given the resources available, technical, medical resources available. And also, we are giving extra value to those services intervention that save lives, that have immediate improvement in health outcomes of the patient. Those are some of the criteria we followed to design a service package for oncology services in Rwanda. I don't know. It's not working. In this process of benefit package design, priorities have to be made. It's not easy. Are we prioritizing breast cancer? Are we prioritizing prostate cancer? So very critical decisions have to be made to ensure that the country is deciding an affordable package that can be paid using public funds, because we know public funds are sustainable and reliable. Because if you start to say we are going to pay for these services, when we rely on partners in the health fund, we rely on funder, anytime the resources may not be available. So that's why we need to make sure that the decisions that have to be made are really to be made using the public funds. So we were requested to pilot with cancer for different reasons, because there is a range of interventions here in Rwanda. There are some life-saving and interventions. There's a very high political will in the country to align with health systems or needs and objectives. And also there are also some relevant criteria, as I said, and also we have cancer treatment guidelines in place, we have centers in place, we have clinicians, well-trained clinicians and providers in different hospitals and settings. So therefore, it makes sense why we started these pilots of using evidence in the designing health benefit package on cancer. Some of the people were asking, we have people with disability, why have you not started with disability? So we need to have a very strong argument to justify why we piloted with cancer. In the very beginning, we started with 10 cancers based on the burden of disease and stuff. But when we presented to the evidence to the committee and to the minister, they said, why 10 cancers? To go back and be inclusive, look at all the cancers. So we have to go back and work to add additional cancers. Someone is laughing here in the room because it's part of the committee. They were chasing us, why 10 cancers? Yes, we say that there's the most common, the most prevalent one, but they said for inclusion, we need to be comprehensive, so that we say that we are done with cancer, we know the cost, we know the resources required to be able to start treating cancer on a large scale, not just focusing on fewer cancers. Yes, of course, they are the most prevalent, but we have to be comprehensive. So now, the second round, we had 67 remaining cancer on top of 10 cancers we have just presented. And then we worked with the experts in the field to group those cancers based on the treatment modalities, based on a number of criteria. And then we also use stratification processes to be able to guide the deliberation and decisions throughout the health benefit package design processes. To be able to undertake these health benefit package processes, we have 3 teams in place. We have an assessment team composed of experts, especially health economist experts, clinicians, who are able to generate scientific evidence, to generate evidence on different criteria. I say the criteria on the burden disease, cost effectiveness, budget impact. We need those people with expertise and experience to support and accompany this journey. We also have a committee of experts. We called it ad hoc committee, the one which is in between the health benefit package committee and the assessment team, which is also a multi-stakeholder team that really helps us to review what we did, to provide insights and critical assessment of the preliminary work done by the assessment team. And then you have the Health Benefit Package Committee, as I said, composed of 17 people, which is responsible to make recommendations and also to present the recommendation to the Minister of Health for validation and approval. So we have a validated process, which is there, which is really a very rigorous process. Next. This is the same process. We look at the services, what are the cancer services currently covered, which one are not covered. We collected evidence on different criteria, and then we do a prioritization throughout the appraisal process. We trained people because it was the first time to do an evidence-based process. We trained the oncologists, we trained the member of committee, we trained everyone to be able on the same page. And then the assessment process, which was done by the experts, has the main objective of this process was to generate evidence on different criteria, on 9 criteria that were presented in the ministerial instruction. Next, please. We generated the evidence on cost effectiveness, on budget impact, financial risk protection, burden of disease, feasibility of implementation, the target groups, and so many others. For some of the criteria, we used local data, especially for costs. We were lucky that we have a costing, government of Rwanda has undertaken a costing exercise. We use local data, and also we use, where need be, international data to feed our costing exercise. Regarding cost effectiveness and burden of disease, we use a combination of local data. For burden, we use the cancer registry information to have information around the presenting incidence, but also IHME data to have an idea the population needs. We also use expert judgment on some of the criteria, especially on feasibility, life-threatening, and effectiveness of some cancer drugs, some cancer interventions, drugs, and services. So, which means that we use a combination of data and the methodology to be able to generate evidence to inform the design of a health benefit package for cancer in Rwanda. Next. Next, please. In order to be able to build a cancer package, we used NCCN framework. I think clinicians in the room understand that this is one of the framework which is widely used by the clinicians to select the most appropriate pathway based on the available resources. In the basic package, we found that we included those essential services that provide basic minimum standard of care and also that are more likely to improve disease-specific outcomes. And in the core package, on the core resource, we included those services in the basic plus additional services that provide major improvement in health outcomes that are also not cost prohibitive, which are not very expensive. And then the enhanced package, we have those in the basic, those in the core, but also those very fancy drugs, expensive targeted therapy, but most of the time, most of them, they are cost prohibitive, especially in resource-poor settings like ours. This is the framework. The framework provides what should be done in the workup, what should be done in the staging, what should be done in the management. The NCCN framework is very comprehensive to guide the design of a comprehensive benefit package for cancer services in a resource-poor setting like ours. So as I said, for each cancer, we use the cancer treatment guidelines, we use IHME data, we use cancer registry incidence information. We also specified package we have 3 packages, the basic, as I just mentioned, the core package, and also the enhanced package. And also we worked with the experts to make preliminary recommendation to be taken to the Health Benefit Package Committee. This is one of the examples of a benefit package design. As I said, the basic, we have those cheap, not very expensive interventions. In the core, we have those very effective, those interventions that can improve health outcome of the patient, while in the enhanced package, we have those expensive, of course, cost-effective intervention, or those fancy drugs intervention, but with lesser health improvements when you look at the cancer treatment and health outcomes. This is an example of cervical cancer basic package. That's how it looks like. Remember, we worked on 47 cancers. We started at 10, we added 39. Just for illustration, I'm just giving you just highlighting some of the examples of the package that we have designed throughout this process. When you see, for instance, prostate-specific antigen in the NCCN, this intervention is recommended to be enhanced. But based on the conversation we have with the expert, they said no, given the level of investment the government in Rwanda has done, this should be in the core package because we have the capabilities and the resources in the country to implement it now. That's why you see some of the intervention, initially they were enhanced, but through the deliberation and the conversation of the experts, we decide to move from one package to the other so that we can fit to our context. We're not swallowing what is in NCCN. We are trying to contextualize and customize to our local context. Next, please. Continue. This is a gastric. This is a laryngeal for head and neck. So we did a costing because we need to know how much resources are required so that the government can start paying for these services. We did a normative costing. We use a MOH costing. We use CBHI tariffs. We look at the frequency of each services across, if we have a patient for 5 years, how much the cost. We look at the percentage of the patients that need to get that treatment based on the stages of diagnosis. We use local prices, but also we included some of the highly expensive drugs, especially the most common targeted therapy, that might have increased the budget impact in terms of resources that are required in the near future to start paying for cancer. This is an example. How much does it cost Rwanda to treat a patient using basic package, a patient with prostate cancer, using intervention, the basic package, you pay $217 US. If you are to use an enhanced package, it's very, very expensive. And here we are treating everyone. Remember, we want to advise the government where resources should be allocated. So here, if you decide to treat everyone from stage 1 to stage 4, this is the amount you have to spend for each package. We have the basic, we have the core, we have enhanced. This shows that we know that treating cancer is very expensive, but this here we are giving data, local data, to inform decision. Where the resources should be allocated first when it comes to treating cancer patients. Next. If you are to treat stage 1, stage 2, and 3, you can see the resources we are saving some resources. The next slide, please. If you are to treat stage 1 and stage 1 and stage 2, if you are picking up cancer patient area enough, there will be more savings to the healthcare system because of the cost of treating patients using service package for stage 1 and stage 2 is very cheap. This echoes what other presenters said. We need to invest in the prevention, in early detection. So now, to your knowledge, the core package was recommended for these cancers. After putting together all the information, remember we as experts, we generated evidence on 10 criteria. We have to design a very simple and simplified document that should be presented to policymakers so that it can be able to make an informed decision. We generated what we call an evidence sheet. So we have almost 100 evidence sheets because we have 3 evidence sheets for each cancer.
three evidence sheets for one cancer, because we have a basic package, we have a core, we have enhanced, and then we have 49 cancers. So we generate almost 150 evidence sheets in this process. And this color gives an idea. When it is green, it is very good. When it is yellow, it's a moderate. When it is red, it's very catastrophic. So we use color coding to help policymakers, to help those taking decision to digest the information and to make informed decision for simplification purposes. Next. What are the expert recommendations? As I said, most of our people in our team have limited understanding of modalities of treating cancer, but we have to rely on experts. We worked with experts closely so that we can come up with a recommendation that can fit into our context. Next, please. Those are the list of experts. I think these names, you are familiar with these names. Those are the people who contributed to this exercise in terms of reviewing, selecting, and they were into 3 groups, and they worked with us for 2 years. Next, please. You see, some were like this. I don't agree with you. The conversation was so hot because they are really defending what we are proposing to the committee. Next, please. So their mandate was to review the package, was to review the evidence, was also to provide preliminary advice to the Health Benefit Package Committee in terms of intervention to be included. Those are the recommendations. For breast cancer, they recommended the core package. For carcinoma, they recommended basic package. You can see that there are, remember, it's the combination of factors. The technology, the available skills, the cost, the effectiveness. There was a combination of factors to decide on services to be included in the service package for cancers. We also presented the evidence to the committee, the Health Benefit Package Committee, that was what was nominated by the minister. They agree with the expert recommendations, and then they recommended the core package for stage 1 up to stage 3, and the no-enhanced package was recommended for all the cancers. And also they recommended the review of the co-payment structure. I think we discussed about this, so to reduce financial toxicity as discussed. And also they also recommended that what the budget implication. Next. If CBHI has to pay today, this scenario C, 11 billion is needed every year to treat 47 cancers using the package that were recommended by committee and CBHI. Next. What are the lessons learned? The main challenge with data availability was local capabilities, but also the health benefit package design requires data, capacity, and time. We were lucky we have a strong leadership, political commitment to universal health coverage. There was accountability, and also the use of this process requires a credible and transparent process. Finally, engaging a local and international experts throughout the process was critical to define a legitimate health benefit package for oncology in Rwanda. Thank you very much for your kind attention. Those are the experts we worked with throughout this exercise. Thank you very much.
Thank you, Dr. Stella. Please give another round of applause to Dr. Stella and the team which helped to make sure that this report could be, available. Thank you so much. Now, let's go to the next presenter, who is Dr. Regis Hitimana. Regis is a health economist now with a PhD and he's the chief of benefits, at Rwanda Social Security Board. Actually, he was also part of the team, and he was very helpful. By the way, before we talk, we are very helpful that RSSB is a very good partner in making sure that we deliver the accessible and affordable healthcare in Rwanda, and now this time cancer is on board. So welcome, and share us with your insight.
Thank you, Dr. Theonest. I'm happy to be here. I didn't expect a room full of people on this holiday. It shows the interest, and I'm happy to represent the CEO, who also has the name of Regis, who could not be available. But to this topic, I think I was more close to what they were doing for us and with us in the last almost 1 year. So as I said, I work at the Rwanda Social Security Board since I'm now celebrating 4 years, but I came from the same department as Stella. So it's a pleasure to use evidence to inform policy. And part of what I do, I cover, sometimes my title doesn't mean a lot. It benefits, some people think I'm in the Human Resource Department. Those are the people who give benefits. But in social security institutions, benefit deals with, we collect contributions and we pay benefits, and anything extra is invested. So that benefit payment is what I'm responsible for the 6 social security schemes that we manage. 2 of them are health insurance that cover about 90% of Rwandans. Now, mine will be very short. Actually, Stella covered half of my presentation. What I want to say, sometimes we think we are far away, but we come more far, and we are doing great compared to the region in terms of universal health coverage. Spending per capita, spending on health, when you compare ourselves with the region, actually countries with a similar GDP per capita, none of them is comparable to us. We are now comparing ourselves to middle-income countries and high-income countries. Not high-income countries yet, but middle-income countries, yes. If you look at Uganda, Tanzania, we are far away, but Kenya is ahead of us in terms of spending per capita. But Rwanda has done a good job in terms of financial protection and service availability. Financial protection, in a way, you can't reach financial protection without organizing a prepayment system, because when you talk about cancer, is a good example. When you pay at the service as the service delivery, actually you end up selling your assets. But when you prepaid, then you pull the risk, and actually you reduce what we call out-of-pocket expenditure, because you pay little in advance, and together with neighbors and other citizens, you actually help people not to go into poverty. And people look at this using one of the indicators. They look at how many people actually spend more in relation to all other expenditure, spend more on health, and there's no country to compare in the region. When you look at 25%, when you spend 25% of your own health, it's too much. In Rwanda, it's only about 1% that spends about that, and it's 0.1 when you go to 10% benchmark. But this is average. We know that average don't tell us the true story. There is 1 or 2 citizens that probably can be impoverished because of healthcare. But when you look at the population level, I think we have done a very good job. The other thing we need to discuss is about UHC service coverage. You can have very good insurance. You say 90% are covered, but covered for what? we need to give them the services. The government has done a very good job, but we are far away. On the index, Rwanda was scored 54. And when I tried to dig into WHO data, and I invite you also to look at it, so we still have a long way to go in terms of human resources for health, in terms of NCD services that needs to be available at primary health care. I know RBC, Dr. Francois and team are working hard to achieve this. So we need to look at both. Our people have access, and access to what? To services. Now, reducing out-of-pocket, as I said, comes from organizing communities to do prepayment instead of paying at the point of care. In Rwanda, I think 20 years ago was a good period for Rwanda. A few years after the genocide, a lot of ideas emerged, and we are still enjoying what came out of that. We have two health insurance schemes that were born almost at the same time in early 2000s. One is community-based health insurance. I think the room is full of, most of you are Rwandans, maybe I should skip this. But these two schemes managed by RSSB, one focuses on the informal sector. Contributions are done by families. There is a contribution rate per family depending on a socioeconomic category. But as I will show you in one of my slides, this is no longer making even 40% of our income because government has put a lot more resources into the scheme. But also something that also we have done great is cross-subsidization between insurances. So people who are in this room, probably you have maybe Sanlam or Rama, hopefully some of you. So whatever you pay, there is a percentage, probably you don't even know, there is a percent that goes into CBHI and doesn't give you right to access to the services. So private health insurance contributes 5% and Rama contributes 10%. MMI also contributes 5%. So every $100 you contribute for your health insurance, you are supporting your uncle somewhere in rural area also to get services, which is something commendable. And the government earmark some sources to CBHI. Rama is fully funded by employees and employers, mandatory to government employees and optional to private sector. Private sector now we have about 25% of our members from the private sector. It's optional, so you get to choose between us and about 6 other private insurances, but we have seen more people coming to us. This is the story of CBHI summarized in one slide, from 7% to 90% of people without another insurance. And all the other insurances together, they don't even make 6%. No, it's around 6-7%. So it means almost all Rwandans are eligible for CBHI, and we have enjoyed sustained growth in coverage. But this also comes at a cost. Since 2011, we have not changed the contribution rate. So this is the time we now start thinking about how much are people capable of paying. This is maybe a slide that many Rwandans were waiting for, because there is always a story of CBHI that is incapable of paying all the expenses, but since a few years ago, we started seeing revenues surpassing expenses. But it is with the current package. It's before what Stella says is included. And if it is included, we'll go back again. These lines will cross again. That's why we can't stop mobilizing resources. It's time to add services, but it's also necessary to keep this scheme live and sustainable. As I was saying, since maybe if I come back to let me see. So what happened in 2018-19, 1920? Maybe in 1920 there was one government subsidy to CBHI to cover previous deficit, so about 19 billion. It was a lot of money. But it's also the time that government realized that this is not sustainable, because we need to find more ways of financing CBHI that don't wait for, because there was also a lot of damages to service availability. When you wait until the scheme falls, then they first default on their obligations, they delay paying health facilities, and even the services that we are supposed to pay, facilities are not capable of providing, because, you know, when you were not paid, you don't go to Rwanda Medical Supply to get supplies. Of course, there is a nurse or a doctor paid by the government who will do consultation for you, but that is not the whole service. So that's the time government started thinking around how do we sustainably finance CBHI, and that leads to this story of the situation where, oh la la, one slide back. Yes, this is the slide I wanted to show. So 13% came from other insurance contributions, private insurance, public insurances, employees' contribution. Every person who receives a salary in the formal sector pays 0.5% of their salary to CBHI. Telecommunication companies contribute about 0.3% of their turnover. For every liter of fuel you take, you are paying 20 Rwandan francs, and CBHI collects about 6 billion from this source. And research that Stella and colleagues do, when they pay, they have seen their Rwanda National Ethics Committee fees doubled, and half of it comes to CBHI. RFDA for product registration, tourism, but other government contributions that don't have a name at all. So these are the sources that are directly given to CBHI without going into the national treasury. So it makes us more independent and more safe in terms of resource collections. Most of them are paid on quarterly basis, so we can sustain our service delivery throughout the year without always going to government for budget requests or additional resources. But we also, CBHI is one of the most efficient schemes, and there are probably three reasons that that helps us to be efficient. One of them is enforcing primary health care as the point of entry. You know, going to a district hospital requires you to have a referral note. People are not happy, but if you don't have it, there is no CBHI. So 85% of claims that we receive come from primary health care, but we only pay 35% of the money to primary health care. So it means, actually, on average, from health center to district hospital, on average, we pay 10 times to a district hospital from primary health care. So you understand that we are behind RBC trying to task shift to primary health care. We want a strong primary health care that also has sufficient resources to provide services, but that's the only way you can have a scheme that covers 11 million Rwandans alive. Otherwise, we can't survive even 2 years if we remove this. Second, we contract public health facilities. Private sector will come and say, oh, why don't you contract us? And we tell them, this is a public tariff. If you accept it, tomorrow we sign a contract. They look at it, they don't come back. So we negotiate because there is, we know there are subsidies that go to public sector. And of course, we are now thinking of provider payment mechanism. The current payment mechanism we have is fee for service that is known to incentivize over provision of care. So we want to move into capitation for primary health care, probably starting this year, and DRG for hospitals. Oh, yes. Why are we thinking about efficiency? It's because the future without efficiency is not possible. People who are used to global burden of disease studies, this is one picture that shows what happened in 20 years, where non-communicable disease that you see in blue is now taking the scene, taking over from the red, which is communicable diseases and maternal and child health-related diseases. On the other side, you look at the life expectancy, how we come from 45 years now to 70 years. It means, as an insurance, future expenditure are estimated to be, you can't stop them. So we need to be efficient. We also keep reflecting about universal health coverage. It's not about having everyone in the scheme, but also, I talked about it, also the package we offer, but also financial protection. What Stella talked about, and for cancer, we are very, very careful. As this is going to be added on the package, we are looking at the copay. So if you give me access to a 10 million service and you expect me to pay 10%, actually you are not giving me a service because that 10% will not be affordable to me. So I can't say anything now, but this is something that we are working on. And also availability of drugs when they are not available, because we don't contract private pharmacies, then it makes it a challenge because people have to pay out of pocket. But of course, we'll also keep adding services. Now, I think I'll skip some of the slides to go to the last one. If you, next, please. Oh, yes. So this is a simple picture of the cover today. CBHI covers diagnosis, including all investigations, lab, imaging, surgical procedures, radiotherapy. But when it comes to chemotherapy and immunotherapy, we are not yet there. So we rely on other partners, including the Cancer Center in Butaro. But for Rama, we have been covering all the services across. But this presentation is not showing this small box out of a big box, is also sending a message. What we cover is what is known. We know what is not known is huge. When you look at the cancer registry and the global burden of disease, we know that there are cases that we don't see. So when we plan, we need to also plan as we do early detection, as we do early detection, then and we sensitize people, we need to be ready to fit that box. Because we can't say we cover all diagnosis, because we cover the diagnosis that is at least presented to the healthcare provider. So we want to fill all these boxes, both the CBHI one, but also all the boxes, hopefully. It is a journey, it will not happen in one day. Next. So I will skip this. Stella talked about it. Next. I also not talk about this. This is a picture I took from their report. These are the data elements that they need to feed us, because otherwise we couldn't. The 11 million can be 100 million, and probably outcome will be added by 5% or 10%. So there is merit in this thorough thinking and assessment. Next. This is the last slide. What we follow is implementation. Probably you expected to have a date here, but unfortunately I will disappoint you. These new services, we are preparing this technical work, but also on the other side, we are working with the government to mobilize more resources. Because as you have seen, we only crossed the line where expenses are lower than revenues. But even if you don't add anything and you project in the future, we fall again in a very few years. So we need more revenues, and we spent more than a year. Sometimes we might think it's an easy task. It's not an easy task. It doesn't come from the government budget. It comes from a negotiation with some of these service providers. How can you convince a telecom company that used to have 100% of their profit to share with you a percentage of their revenues? Now we are discussing with banks. We are discussing with other stakeholders. But we are close to the end of these discussions. So it's not a matter of years. We can say weeks or months, very few months, we will have very good news that come from the ongoing discussions. But we keep monitoring. We need a digital system to see the services that were offered, whether actually they are being given, whether they are being accessed, and if there is any need for adjustment. This is not one-time exercise. We will keep adjusting accordingly. But on the other side, with RBC and other government agencies and civil society, we need to do prevention and early detection, but also continue resource mobilization and efficiency. So we need to be efficient from what we are spending on today, including also administrative costs that we need to cut with the payment system that I was talking about. We will save a lot, and the more we save, we will be increasing the fiscal space for the scheme to cover more services, because it's not for profit, it's there to provide services. I thank you for your attention.
Thank you, Dr. Regis. A very good, insightful presentation, informative. Give another round of applause to Dr. Regis. For me, the take-home message is that in some weeks, some months, some weeks or some months, we'll be hearing the very good news that we can deliver the whole treatment modalities, chemo, radio, to the package that was proposed by Dr. Stella and the team. Thank you so much. So time is not on our side. Professor Bagenda, we are going to give you some minutes to tell us some of your research and what you have found that can be copied here in Rwanda in terms of universal access. And then we give like 2 or 3 questions, to end up, and then we end up with this conference. Thank you so much. Dr. Bagenda, please. Can you hear us?
Yeah, let me get on, and then I wanted to share my screen so that I can run the presentation that I have. Hopefully you can hear me now.
Yes, we can hear you. Okay, go on.
And let me see if I can get the presentation running. Hopefully you can also see the presentation.
Yes, there you are.
Thank you very much. First of all, I think a lot of my presentation is going to sort of complement the presentations that have been done at this point. What you see here with my affiliation at times might be misleading. I've actually spent a lot of time. Right now, I'm based in Nairobi, in Kenya, but I've spent a lot of time in the region, in various places, including actually in Rwanda. As you can see here, these are photos which I actually took myself. Indicate to you that, especially in terms of interaction with the cancer aspects within Rwanda, familiarized myself a little bit. And this was with the help from our colleagues of yours at RBC. And as I picked these graphics just to show and highlight aspects which deal with screening, which deal with care, which deal with testing, and so on and so forth, and also which deal with reporting and registry. And I think one of the things I noted for me as we go through our presentation was actually that Rwanda was already far ahead of a lot of the region because I'm originally from Uganda, so part of my presentation will emphasize that aspect of it, but I've also spent quite a bit of time interacting with the health services in Tanzania, whether it be at Ocean Road, but as well the infectious disease aspects. Hopefully, following my presentation, you're going to be able to take away a couple of things. For me, my emphasis is going to be on things like how we're spending time to determine, anticipate conditions, people, regions, situation, contexts, and even circumstances which we should prioritize our limited resources on And as well, are we spending the time, enough effort and time to assess effectiveness and reach, especially as regards equity of solutions or interventions of things that we know work, because we know that there are things that work. Some of them are very easy and accessible. Some of them are more expensive, as has been noted through presentations. And then do we understand how, why, and where some of the solutions that we are pressing for and that we know that would be important, why they are not working, or if they are working, why they are not optimal. And lastly, can we optimally and efficiently use the meager resources, especially to see that we are getting the most optimal and effective and equitable outcomes in a given community within the physical space that we have. So you see me leaning towards the direction of trying to see how do we use that data, especially to anticipate the problems amongst which people, where and what, and also to determine the optimal solutions, again, within that same context, and also to determine whether we are making progress and also the bottlenecks and impact to those problems. Here, I'll start by, first of all, highlighting, this is from 2008, so this is actually during my time, again, in Uganda. As I said, I've also been in Uganda, where I'm from, and here, this was my student, an MPH student, in 2008, whom I decided to push to look at the cancer trends within Uganda over a period of time, a 10-year period of time. And the key aspects here for this student was to essentially figure out, are we in Uganda at that time, are we ready? Are there institutional capacities that are there to deal with the response based on these trends that will come out? And so that was really the motivation of that. And the capacities here would be dealing with whether it's the drugs, talked about issues which relate to data, meaning things like the registries, outreach and care and personnel and so on and so forth. Again, this is one of the outcomes from the student's work that he did. We noticed one, that obviously there were various cancers that we were seeing, and the cancers were actually, there are some which were growing in number and some which were getting less. But what was interesting was also the breakdown. I think I had in the previous session the aspect, obviously, that males were not being emphasized enough and so on and so forth. But one of the things here was, it was clear that this is a breakdown that shows the 10 most diagnosed cancers as based on what the student figured out. And as you can see, things like Kaposi sarcoma, which was still the most prominent in Uganda. You had cervical cancer, but you had things like breast cancer coming up. But you can see that a lot of cancers actually tend to include a lot of women, including the cancers that we don't typically, because I know most people, when they hear of cancers amongst women, obviously there's a lot of emphasis on things like breast cancer, cervical cancer, and so on and so forth. But you can see even on aspects which are related to Kaposi sarcoma, they are still prominent in that regard. So you remember I tended to highlight this aspect of who, what, where, and so on and so forth as focus. So those are things to keep in mind as you are trying to figure out what are you going to be doing, where, and for whom. This is another graphic I think that is interesting, again, which was looking at the regional breakdown. Again, we were picking the 10. This endeavor included all the cancers. Here for the graphics, I'm just including the 10 most diagnosed cancers, but all the cancers were all included, including some which were very obscure ones, but they are not highlighted here. But again, you can see the regional breakdowns. If I take, for instance, one of the ones that can be interesting for somebody to look at, if you look at the eye cancer, for instance, one would wonder, that's the one in red. You'd see that proportionately, the eastern region has more of that occurring. Yes, there are not as many cases, but there is more of those types of cases than there are of others. So those are things, again, when you are trying to figure out where you're putting your resources for what, for which interventions and so on and so forth, one would have to be thinking in that direction. And this is just showing you also the trends, what is going on between regions. The other aspect to this regards as to for whom, again here, what the emphasis is to show where the different cancers that you see, where they are occurring and for what age groups. And again, you see obviously things like Kaposi sarcoma, you see them within the eye, cervical, they are all within this 25 to 49, well, not all, but a big majority. And we know the Burkitt's lymphomas, for instance, those are typically in the younger ages. But one of the things we were seeing amongst also many, this was a dissertation, so it was a big thing, but there were also cancers which were appearing even amongst the young, which were not the typical ones, like which were known for the young age groups, like Burkitt's lymphoma. So those are things to start thinking about also when you are dealing with resources, but also when you are dealing with the screening and things of that sort. But this is just a graphic, again, to show you the emphasis of why it's important to be able to collect data and start thinking and strategizing and planning, especially where you have limited resources. This was one which emphasized the mean age at diagnosis of the cancers, as was determined within this particular study. And again, I'm highlighting this because one can start to think, okay, I look at some of these cancers and say, this is the mean age at which we are diagnosing them. But if we know the normal natural progression of each of these cancers and when they typically start to show up based on what we know, if we are seeing a diagnosis which is occurring at a certain age, is it late? Is it a bit too late? So is it where we should be putting a lot more emphasis or not? Or is it around about the time? So are we doing as well? So I think, again, this particular table is just to bring those thoughts in mind as to why collecting some of this information can be important in terms of figuring out where you're not being well, where you might be lagging behind, so on and so forth. This particular effort by this student actually also included, remember we're trying to look at the capacities as well, also included the delving into the what we call qualitative aspects. I've just shown you the quantitative, but there were also the qualitative aspects with key informant interviews. And one of the things that showed up were things like the unreliable clinical diagnosis and biopsies. And again, the question would be, what can we do to address this specifically? And the long time it took to send, because the idea was a lot of the specimens were collected and the biopsies were having to be sent to a central part that is in Kampala and back. But by then, the time period that would have elapsed would mean that diagnosis would be late again. Again, what can we do about that? And then there was the issue of people talking about inaccessible services. Those are things to think about. We can delve into what inaccessible means a little later. Again, aspects that came up within these were issues of underfunding. Highlighted were aspects of obviously salaries and equipment, and also the aspects which deal with the aspect that that a lot of the key things were being funded, were being funded externally. So the issues would be, how can government come in? What is its role in funding these, and what can be done specifically about them? Aspects of space, working space, were prominent as well. And the space here included things like, space for examination. We again have been talking about the aspects that people are not screening, or people are not being diagnosed early, and so on and so forth. But again, even in many of these places, including in some urban centers, there are no rooms designed or specified for diagnosis, and so on and so forth. And these are issues that are critical as well. So there's the aspects of understaffing. Again, in this particular case, we were looking at 5 doctors for about 10,000 cancer patients.
Dr.
But beyond
Professor
the
Bagenda,
doctors,
sorry,
Yeah?
maybe for cutting short, we are running out of time. Please try to make sure that we wind up. Sorry.
Okay. So I think since we're running out of time, let me see if I can just go into some very. Let me just go into one of these. I'll probably just highlight this study because this has just come up. This was in the papers yesterday in Kenya, and it highlights this study, which says that Kenyans shun cancer screening over costs and fear of diagnosis, and this is what this study shows. So the big part of this study was saying that cost was a big issue. 75% of individuals were showing up with late or advanced, very late stage advanced cancers, but a big part of this was due to cost, and a big part of it was actually there was the cost of transport, but there was the anxiety over cost. And I think part of the earlier presentations have delved on aspects which deal with cost and how that is alleviated and through insurance. Rwanda is obviously well ahead of many of these other countries. This is the actual study if one wanted to see how to deal with it. But again, I think if we are to take this information, it is how do we take this information and use it? What I've tried to do is try to see how to set up the odds ratios so that you see how the odds ratios went based on what was discovered as the key factors for late stage diagnosis of these cancers. Cost of travel was critical, and then obviously the anxiety of cost of care, which means that when just the previous presentation, when somebody is dealing with insurance and ability to pay for those things, you are dealing with a lot of the key issues that are actually behind why we see some of the late stage cancers being seen, and so on and so forth. The other aspect is obviously the context matters. So you have to know which issues. This is just another study where one would look at things like what are the things which were most likely to be associated with late stage cervical cancer, and you could see education and residence in Kenya, but income was the key thing. So one has to be very specific on what they are looking for. So since we are left with very little time, let me just say one more thing.
Please, Professor Bagenda, we are now running out of time. 20 minutes past
time. Let me stop there. Let me stop here then for now. And I'll just
thank you. Give a round of applause to Professor Bagenda for his insightful. By the way, time is an enemy, as they say. I understand that you are very enthusiastic and you are expecting to ask more questions. Actually, you panelists, thank you for coming. This is the bread and butter for cancer care in Rwanda. When we talk about RSSB, about the team that you led, we want to understand more what the process may be, when the availability of a drug will be, implemented. what type of maybe of drug, or what is the package really that will be, accepted, because we are talking on behalf of our sisters, our mothers, our brothers, on us because of ourselves. Yesterday we said that this is not for other people; it is for us. Okay, so we shouldn't be, rejecting this to other people. This is ourselves. We are fighting for ourselves. So I am now receiving at least 2 questions. 2 questions, and this time now I'll be taking both, gender, male and females. So Aline, you will be asking your first question, and then let's start by the younger. Okay, please take the mic.
Thank you for the time. I'm Wimba Zarine. I'm research assistant from RMH, and
Let's be brief and precise
yes,
and clear.
I have a pleasure to be with RISSB, where 75% of Rwandan population belong. My question is, what are the mechanisms of RISSB treatment access, especially cancer patients? Once it comes to private pharmacies, sometimes patients are told stock out, or they have to pay top up, while medication are served to private clients. Thank you.
Next.
Thank you so much. My name is Darius. I'm a medical student at the University of Rwanda, and I'm going to address this question to you, the moderator, as a policymaker here in the room. As we say about universal health coverage, we say about that some diagnoses are being covered by Mutuelle de Santé as one of the programs that is here. But the problem is that most of the people doesn't know what is really happening, and the thing that you developed today is the strategies for strengthening healthcare system for better address the growing burden of cancer, including the workforce training, infrastructure development, and process improvement. How are you planning to do with it? What are some infrastructure you have built, and how are you trying to engage most young people within the country who are willing to facilitate this strategy and this policy improvement? Thank you so much.
Most welcome, our future doc.
Thank you.
Another round of 2 questions. I start with our partner, Abbott, and then...
Okay, thank you, Dr. Theonest. My question goes to Dr. Regis, of course. Yeah, you didn't say a date. I know the date is secret, but maybe it will come out, right? So my question was about how can we really implement routine diagnosis of high-risk HPV in our hospitals? Maybe if patients can pay this using Mutuelle or RCCB insurance, at least every woman who visits the hospital can take that test. Not just waiting when Dr. Theonest and the team of NC Division, LBC, will conduct a campaign or a mass screening. Just as they go to the hospital, they go to the service. Thank you.
Thank you, Emma.
Okay, thank you. My name's...
Gave, a speech to the Bismarck, if I remember.
Thank you. I'm Jean Bosco Vigiriman. I'm an oncology program manager working at Butaro Cancer Center of Excellence. My question is addressed to Dr. Regis in RISSB. We have been experiencing issues, especially in paying 90%, and these have been really impacting the care that the patients are getting. So how are you planning to address this issue? Because patients are really facing this challenge, and this issue is really coming back to them. And many hospitals, health centers, they are really claiming this issue of late payment from your side. Thank you.
Thank you. I think now we can take those 4. I think maybe 3 have been addressed to Dr. Regis, and then 1 to me. Starting maybe by me. Darius, you asked maybe 1 complex question, but I made it like 2. I split into 2. 1, you are saying that our population don't know actually what we are doing and what is available. We understand, we know that. We don't even need to talk about the normal population, the general population. They start by our healthcare providers, even ourselves, most of us. We don't know what we are doing, available services, and the referral system. That's why, to start with this, we usually, in every quarter, according to what I know in the program, of course I am new, but I know what is being done in the program now, we have planned to enroll like a basic oncology training to make sure that our general practitioners and some nurses working in NCDs, because the oncology program actually it is part of the broad program of NCDs. So that nurses and GPs get at least the basic knowledge about signs and symptoms for cancer and the basic management, but also they understand the referral system. And when we are doing this, these people, we make them like training of trainers so that they can help other people. The issue is linked about other many challenges, that it is turnover of people, people that we train, they go, but this is on ourselves. So what we are doing now, answering what has been asked in the previous presentation, is about now making sure that, for example, from all schools that are teaching healthcare teaching schools, being allied healthcare professionals, councils, nursing schools, being nursing and midwifery, medical schools. From the next 5-year health sector strategic plan, we are strategizing to make sure that they are trained on cancer, first of all. To make sure that people who are graduated, they get basic knowledge of cancer. For example, let me say, emphasize on what I'm saying. I am an oncologist, but there is no oncologist here who can say, maybe when they are doing consultation, if they feel, for example, a patient having fever, they say that they can't ask for blood test for malaria. Because in general medicine, we have got that basic knowledge. But we have found that in curriculum for especially nursing, people who meet many of our clients, midwifery, people working in pediatrics, they don't have any basic knowledge on cancer. And while we are, taking the program, they say, we don't have any knowledge, you need training. So in order to reverse that mindset, you want now to review the curriculum so that when people graduate, they get among their curriculum the basic knowledge about cancer. That's what we think for healthcare providers is going to finalize. Sorry, is going, to solve the problem. And this is being finalized within next 2 weeks in health sector strategic plan. When the HSP plan is, has captured that, we put in our strategic plan for the division and the program, and then we'll start implementing that. That's how we think that we can solve. General population is about education. We do it in, media, radio, TVs. We thank the media people that are here. That's what we are doing. Remember, in last 10 years, when we were talking about HIV, people are not knowledgeable as they are now. What they have done, it's about education. So we are inviting you also to help us in spreading the news about cancer, and also, but don't spread the rumors and bad news. Spread that cancer is there. We have an issue that people are, presenting at late stage, but what we are doing is make sure that people get knowledge, knowledge about it. They present at early stage, you treat them. Okay? Thank you. Then engaging young people. You are talking about medicine and other societies maybe. So you are most welcome. Come, join us in a fight against cancer. We'll be helping you. We'll show you what you do. And we are happy to, to be a very big team that is collaborating on this. Thank you so much.
Welcome.
Yes, thank you. The first question about access to medicine, I think. Why don't we contract private pharmacies, and why don't we protect patients from paying out of pocket to access medicine or to top up? So the two schemes we have two different policies. RAMA contracts private pharmacies, but CBHI has not yet started contracting private pharmacies for many reasons. Number one is maybe people in the room can understand, but an average member of CBHI will not understand, because a big problem that affects my health, and you respond with an operational discussion or institutional arrangement, I think that's not a good message. That also puts pressure on us to give a solution rather than just an explanation. So we know in CBHI, the policy we use, we contract public facilities and we expect them to provide medicine, at least all the list of essential medicine list, depending on the level. But it happens that they run out of stock. It happens that probably they don't find enough in Central Medical Store, Rwanda Medical Supply. But on the second, I think there is a solution that I don't know why they don't use it very much, to also go to private pharmacies, because it's allowed when RMS doesn't have the medicine. Why CBHI is not going into private pharmacies? I think private pharmacies, as RSSB, we do both, and we know how complicated it is. A lot of fraud, no regulation in pricing. You know, today I can budget at least my spending on fuel, because I know government is regulating prices. But if you go in a country where there is no regulation, you wake up, prices double. That is what is happening in our pharmaceutical sector. And that's why the government of Rwanda, the Ministry of Health, has come up with a policy which is not yet implemented, at least to regulate prices. And I know Rwanda FDA is working hard on that, but we are yet to see it. Otherwise, we have, I'll give you two experiences. One is a recent fraud we detected 2 months ago. They just create prescription from somewhere. And you see a doctor who doesn't even know that it is his name and his stamp, and we know when we are going to pay. That is an example, which we think the ongoing digitalization of the whole process, including prescription, will at least address that. Second, pharmacies, private pharmacies, I think they are eager to earn a lot of profit, more than anything. So yeah, on a price we agreed, we signed, you go, they just tell you, no, it has increased, this is a matter, you have to pay by yourself. So we actually, there is what we have been doing, but we're also improving on monitoring the implementation of the pricing we have. But we think with two things: more availability of medicine in public facilities, and we play a role, we know. When we pay on time, which we do, maybe responding to the other question, we do pay on time. Those stories are of the two years ago, because we have now resources I've presented, we pay on time. Below the contractual timeline, that is for sure. So that is our responsibility, but also it's a responsibility of the managers of health facilities to prioritize medicine, to know that I need to have sufficient stock to serve our members. And soon with our digitalization, we'll be exposing those that are actually sending patients outside the health facilities. But we know we should be doing this more. So we hope with the price regulation and digitalization that removes the fear of fraud, probably we can also think about giving alternatives to CBHI members to go to private pharmacies. But we are not ready. If we do it now, the scheme will collapse the next morning, because we are talking about out of 20 million consultations that happen in a year, more than 20, so it's 19 million are on CBHI. So you understand, even if it is 100 increase on spending on medicine, we can forget about this cancer. If it's 1,000, then you forget about the package we are adding. So it's not a scheme that you wake up and just venture into an unregulated sector that is driven by profit and without digital system. But all this I'm saying is in progress. So next year we should hear good stories. Extending the question from Gilbert, extending diagnosis in public facilities actively, because today I think it's done through public health campaigns covered by RBC. I think it's a very good suggestion, and we should maybe it's part of it is there, as Stella is saying. Among what the benefit package discusses is also the diagnosis has its own cost effectiveness. So if you are spending billions only to detect 1%, probably you can narrow down the group, maybe this age, these preconditions, then I prescribe. But everyone who comes, it has to have sufficient prevalence for you to deploy diagnostic capacity. So it's something we are ready. It's part of the package that will be implemented, and we'll be monitoring and probably expanding more scope. And in parallel, RBC and MOH also giving capacities to public hospitals to be able to make the service available. Copay, 10%. We know 10% when you go to expensive care like this is a financial burden. We are working on revising the payment ministerial order, which has the element of how much people pay, but also as a premium, but also as copay. So we are exploring two policy options, and one of them will be adopted. One is if we have you have heard that recently the Ministry of Law Government has launched what we call social registry, which is replacing Ubudehe. So we know who is capable of affording how much. Then we can set copay depending on how much people can afford. The second, which I think is likely to be adopted, is capping copay. So we keep 10%, but we cap. If it is above, let's say 50,000, you stop. The scheme takes over. I think this is a policy that works in some of the countries, including Sweden, the case that I know. So this is the policy that might come. We will not remove the policy. You know, the policy actually, as we speak, all the other private insurance adopted this policy, I think 2-3 years ago, because expenditure were like, when you know it's free to go to the health facility, nothing you pay, there is a way you behave. But when you know you have to contribute, even if it is symbolic, at the health center it's 200 francs, but we have to have it. It's symbolic, but it's a policy that you find in most of the insurances. So we keep it, but we will cap it in order to avoid any catastrophic expenditure at the service utilization. Thank you.
I am sure there may be more questions. I understand. You, Stella, sorry. Time is against of us, and it was the time for resolutions. We have made like some 10 that I can read here. We will summarize them and then submit to RBC and E3 management for other people to see them. So 1 minute. From yesterday, we have got different presentations discussing about how we can now foster and leverage to make sure that cancer care is affordable and accessible in Rwanda. But also we talked about the sustainability of those best cancer care that we needed to make sure that has a place here in Rwanda. One of the issues that people emphasized on is to make sure that we improve our program implementation, all backed by artificial intelligence. AI has been something that people emphasized on, from promotional treatment, palliative, and research. Second, intersectorial and interprofessional collaboration, very important. The third, to produce research, cancer research agenda to make sure that we don't react in what we are doing. We act based on data to make sure that we are proactive, to avoid something that will be coming because we say that we didn't know. And this also comes back on research. I remember the presentation that was done by the keynote speaker, Dr. Numbalo, emphasizing on recommendation from Lancet Oncology Commission. Thank you, Dr. Numbalo. That has been taken as points. Then number 4 was to foster program implementation through partnership with maybe NGO, other partners, but also enforcing PPP, public-private partnership. We found that it can be beneficial on both ways, as some collaboration like RSSB has showed to make sure that there is sustainability of resource mobilization. That also has been taken note. Then on universal health access, to make sure that we decrease and if possible we remove this financial toxicity. We thank Dr. Regis and Dr. Stella and even Professor Bagenda on this mechanism that you have been showing us, how we can work to make sure that services, treatment, medication can be accessible and affordable elsewhere by everybody in Rwanda. Thank you so much. Another round of applause. And if you remember the very interesting presentation that was presented by Brian about building systems that are there to support patient, not patient to support the system. You remember that? A very good quote. So we want actually to work on this because we know that, for example, when we talk about on this issue of people navigating different systems, we are facing that as treating doctors, people coming from different hospitals because there is no single hospital in Rwanda having the same cancer treatment modalities. And due to this, people get lost. And when they lost, some may get radiotherapy or chemotherapy, they miss surgery. You see this thing, there. And due to this, without having a very good system, very good navigation, people don't respect the protocols. And these delays, these loss of follow-up, those are the ones which lead to poor quality of treatment and poor outcome. So this is due to the systems. Thank you so much. With this have been noted. The last one is about promotion of healthcare services for both, considering both men and women. This is being claimed about, that we are favoring women, we are talking about women health, more funding are going for women health, cervical cancer, breast cancer, but men who are partners of our wives, we are forgetting ourselves. A very good promise is that we, after the commemoration of genocide against the Tutsi, we are starting having like a collaborating meeting, which will be strategic between RSSB, Ministry of Health, RBC, to discuss how we can now start also make sure that we avail the simple diagnostic test for prostate cancer, because now it is a third, to make sure that men, they are claiming, my friend, so that they don't feel like they are forgotten. This is a very good point to note that you have taken, Dr. Nyirinkwaya. We understand. Thank you so much. And increase the healthcare workforce, oncologists, surgeon, and everybody. This is being worked by health care workforce department in 4x4 strategy, but we are working together when we are going to refer people because we are the one who know type of cadres that we need. So this we are remembering. That's it. And also one health policy, because we found that there are a lot of cancer risk factors that may not come from, that may come from animals or from environment. Meaning that whenever you are doing our planning for a program, make sure that you involve people from environmental health, but also the animals being domestic or wildlife. That is one policy that is being worked on at RBC, and it was very important to hear about WASH and other people talking about one health policy. Those are the major key notes that you have taken. Maybe if there are others that we would have forgotten, you can reach to us so that we can make a very good summary of this conference. Thank you so much. I welcome the moderators and the management of E3. Thank you so much.